EGD, and they will essentially inject the medicine, very much like a treatment of varicose veins. They'll take the little robotic needle and inject medication in there to kind of cord off or kill off the bleeder. Where in the tubal ligation, they'll either cauterize or what they call band in there. So they'll pull up the variceal into the EGD machine and either put a rubber band around it, like truly band it, and it'll cord it off and die, or they'll cauterize, just depending on their technique. But that's the ligation. So ligation is going to be your band or burn. And then your sclerotherapy is the injection of medicine to stop it. All right, so speaking of metabolism, let's talk about, this is truly your metabolism organ. So if you want to think about thyroid very simply, if your thyroid is overly active, your metabolism's on 5,000. Weight loss, sweaty, hyper, tachycardic, the bug eyes, the exophthalmos that we'll talk about, gonna be just out there. And then hypothyroidism, no metabolism, freezing cold, weight gain, hair loss, thick skin, we're gonna get into that. So, that's just keeping it simple. So hyperthyroid, high metabolism. But before that, I want you to look at the function of the thyroid. It's gonna produce these 4 hormones for you. We know it's T3 and T4. TSH is one that we'll use, that's your thyroid stimulating hormone. That's not produced by the thyroid, but it is a thyroid lab we will look at. And then your reversed triiodtyrosine, RT3, not super common, so you can kind of, put a little X on it. Be aware, but it's not one that you will see super commonly. And then calcitonin, and so this is going to be one where has anybody given calcitonin yet? Yeah. Helps you regulate the amount of calcium in your blood. So if you inject someone with calcitonin, what's it going to do? It's going to take the calcium out of the blood and put it back in the bone. So that is the role of calcitonin. You'll actually inject it. Most of our calcitonin comes from salmon, some fish that we give them. But when you give them calcitonin one more time, it gets the calcium out of the blood and puts it back into the bone. So obviously you see all of the things that can be affected by your metabolism. I don't think anybody's surprised there, but actually the fertility can. So people with thyroid issues have fertility issues also. So just putting that in the back of your brain, because usually that's not linked to your metabolism. But I want you to think about that. So your risk factors for hyperthyroidism. Hi, Anna.
So you have a T3 and then you have a free T3, right?
No, you're on T3. There's not. They check them differently. So it talks about what's available in the thyroid or blood versus what's just free floating and not used. So they're interchangeable. T3 and T4 are produced by, but the free T3 is. It gets more complicated. I don't want you to get down that rabbit hole. But TSH and T3, T4 have an inverse relationship. So Anna's got me on a brain race, so we're gonna ride it. So TSH, I'm gonna do hyper and hypo. And you can figure it out. It's gonna be pretty easy. So if I have hyperthyroidism, my TSH, how much thyroid stimulating hormone do I need if my thyroid's in overdrive? I don't need any. So their TSH and hyperthyroidism is super low or non-existent, because my thyroid, I don't need any stimulating hormone, my thyroid is crazy. And then I will have elevated T3 and T4. Those will be through the roof, and that will give me the indicator that I have hyperthyroidism. So for hypo, it'll be the opposite. I have an elevated TSH because my thyroid is doing nothing. I'm trying to make it work. And I have little to no T3 and T4. And that's how those will be diagnosed. So risk factors would be Graves' disease, and that's where you have a goiter. So what's a goiter? Is a growth. That's on, huh?
That big neck.
It'll be a nodule or thyroid megaly. And so that's your common cause, because that's essentially is your thyroid's growing and replicating, producing more hormone, and that's how we wind up with hyper. Thyroiditis, so if you have an infection of the thyroid, as it's inflamed, it can produce more T3, T4. Toxic adenoma, these cancers, thyroid nodules, just anything on the thyroid that would stimulate it to grow, replace, replenish, produces more T3 and T4. So there's a perfect patient there. They're going to be thin, finger clubbing. So finger clubbing, where else have you seen that go with? Anemia, hypoxia. And so that's due to the tachycardia and the increased metabolism. We need more oxygen demand, and they don't have enough oxygen for the oxygen demand. But your hallmark signs for them is going to be the exophthalmos, the bug eyes. When you think about it that way, they're going to have an enlarged thyroid. You will actually, most of the time, if you palpate your partner next to you, and you don't have to, you will most likely not feel their thyroid. That is okay. But on these patients, you will palpate either a goiter or an enlarged thyroid. And then I went like exophthalmos, the palpable thyroid, and then the severe tachycardia. You see also for your ladies there, you'll have the menstrual changes or amenorrhea, most of that, and then the weight loss. So that's just kind of keeping it, think about your metabolism is really high.
What is the word you're saying, exophthalmos?
Exophthalmos. I'm gonna see if it's on this slide.
Is that the bug eyes?
It's the bulging eyes or bug eyes. I'm gonna look for it on the screen. It's not on this, but it will be on our scramble that we'll play in a little bit, and you'll see that word. But EXOPHTHALMOS.
One more time. Yeah, I'm just.
Let's see. Let's see. EXOPHTHALMOS. That's your bug eyes. So the labs, we've already talked about them. There's your free T3, T4, and there's your lab, but T3, T4, same thing. So we talked about TSH would be low or non-existent, T3, T4 would be elevated, and we can even get fancy and do the thyrotropin receptor antibodies. That's just a fancy extra test, but don't need it. We can do an ultrasound to look for a goiter, for cancer, for those nodules, anything like that that might be stimulating my hormone to grow, replenish, reproduce. EKG, why are we worried there? Because what can tachycardia turn into? We're going to talk about some supraventricular tachycardias and arrhythmias and other danger things. So when their heart's in overdrive, we want to make sure that it's, we can watch it, monitor that. And thyroid scan is just a nuclear medicine test where they'll inject stuff, do a CT, and get some imaging that way. So treatment, obviously could be some radioactive iodine therapy for a procedure. Did anybody happen to look that one up in your prep work? Nope, that's fine. So go ahead, Chuck.
I looked at it.
Oh, you did look at it? So radioactive, got one out of 20, we're not bad. But essentially they'll inject that iodine in there and try to decrease the size of the goiter or decrease the size of the nodule. So because it's radioactive, we have not talked about, no, we wouldn't have had radioactive therapy. So thinking about radioactive prevention, who would you not want in the room if your patient, because your patient is technically radioactive unless it's injected for 48 to 72 hours. So who's immunocompromised, we don't need to be in there, but what was yours? Pregnant people, yes. What are you laughing, what are you talking about? No, why? I mean, so seriously, it could compromise the fetus, so yes, you would not want those in there. Who else? Young children, so children under the age of 6 is typically the clinical recommendation for not being around the radioactive patient.
What about
And
elderly?
who?
Elderly?
not to the same degree. We're more protecting the kids and the unborn, the elderly. I mean, anybody technically does not need to be around, but we're really worried about the pregnancy and young would be there.
You said under 6?
Under 6 is generally the recommended for radioactive. Another thing to consider is, if at all possible, like if they have this treatment and they go home, try to cohort them on one end of the home. If it's a detached style home that you can do that, they need to have their own. And it's gonna be the same stuff when we get to chemo with cancers next semester. Try to be on one end of the home, away from everyone, using their own bathroom, that sort, until the radioactive goes away. So obviously, what is something that's included in our daily diet that promotes a healthy functioning thyroid? Iodine. Where do we get iodine from?
Salt.
Table salt in the Western world, but what's the even better source of iodine? And most of you probably don't like it. No. Specifically, what type of fish?
Shellfish.
Shellfish. So all your oysters and clams and mussels and all those. Fuller's favorite. I'm a shellfish fan. But that's your best. But if for those who don't, table salt is just fine. So, fun fact to know and tell, did you know that we're having a rise in thyroid disease because people have moved away from Morton's table salt into like the pink Himalayan salt, the black lava salt, and all of those things. So we're getting a resurgence of hyperthyroidism because of our change of salt. So thank you, fad diets and all those things, changing up pink Himalayans, bringing it back. So get your iodine in. Thyroidectomy. We can either take off part of, so that'd be your subtotal or total, and we're going to talk about those. So thinking about other structures sitting in there with your thyroid, right in here, right, the little butterfly organ. So what are some complications I might can run into from this procedure? Who else could we hit?
The trach.
Well, could, but before the trachea, who sits right there at 4 points of the butterfly? Who? No, not yet.
It's in
Parathyroid, so we have to worry about, did we take out the parathyroids too? So we're going to talk about calcium imbalances in just a second. I like the esophagus still, I like that. So what would be a sign? So if my patient's at 30 degrees, like most other patients in the world, what is going to be a sign that they're bleeding from here? Because it was internal surgery, they're not going to be like coughing up blood and all that kind of stuff unless it's severe, but. Could have some, what about?
JVD.
You can have some localized edema, cordon it off, but frequent swallowing is going to be your, if they are frequently swallowing, and we would say the same thing with any oral surgery and your neck still come in, those oral facial surgeries. Frequent swallowing would be a sign that they might be bleeding. What's also right in here, so is your, what do you like when you're palpating? Search.
Your final.
You who? Be loud. You got your shut, but y'all start talking and see what you feel.
Oh, your voice.
Voice box. So you could also puncture the larynx. And so if your patient has increased hoarseness or has no voice after the surgery, we need to report that because we may have punctured their larynx. Okay. So with that, let's see if it gets into. I want to make sure the antidote's in there. Yes, okay, it's in there, so I don't have to hit it now. But those are possible treatments. Procedure-wise, we can also give them some medications, which I'm looking for. I did not see those medicines listed, so we'll hit those. You can also give a med called PTU, which is like a propyl uracil, I think is the full spell out name, but you'll hear it called PTU. It is a thyroid blocker. It helps knock it back. Or methimazole, tapazole is the name of the other drug that you may commonly see. But both of those help to decrease the stimulation of the thyroid. So, methimazole or tapazole, T-A-P-azole, methimazole, tapazole. And we could treat with those two medicines, or your most often prescribed. They'll decrease your thyroid stimulation. So obviously, if they are in metabolism overdrive, they have no energy left because they're just burning it off. So we'll allow them for bed rest or frequent rest periods. Promote a calm environment because these people are anxious and tapping their foot and stir crazy, wanting to move. So calm environment and actually just mental stimulation so that they're not in panic mode. Assess their mental status because in severe cases they could kind of hallucinate or become aggressive from the stimulation. Want to, of course, bulk up their diet because of all of their calories that are being burned. Eye protection. That makes sense because sometimes their eyes have protruded so much that they physically cannot close their eyelids over them. And so we may actually have to tape their eyes closed during surgery or for surgery or things like that because even with their eyes closed, there still is portion of the eye exposed. And so obviously the more the eye is exposed, the more drying, so we may have to give some lubrication drops. And there's the tape. Reduce the room temperature because they are going to be excessively hot. We call it heat intolerance. So fans, that's why the fans picture, take a fan to your patient's room, jack the thermostat down, all those things. Linen changes as necessary. Why? That seems silly and you forget about it because that's a 112 problem. Diaphoresis, and when your skin's wet, it's going to break down, all the things. So it seems silly, but don't forget about your 112 things too. EKG, we talked about because of severe tachycardia. We do not want to palpate the thyroid if it's possible. We're going to take this nursing standpoint, we're just going to take them at their word that they have a goiter or nodules or whatever's going on. We'll defer that exam to the physician, provider, whoever they're being cared for by, because we can actually stimulate the production of additional T3 and T4, which would worsen their condition. So that's why all of the stimulation can cause the thyroid to want to regenerate and become active. And then those anti-thyroid medications, there they are. So the PTU and methimazole, we will give them. We're going to teach them about supporting the neck while performing those cough exercises. The reason for that is if they have procedure on that area, you want to, because we need them to do the coughing exercises for the pneumonia, but we also don't need to pop open our incisions on the throat. We don't want to manipulate the surgical drain or prevent pulling. Again, this could be both for thyroid stimulation, or it could be because of we need it to actually get out the blood and stuff, because we don't want to have a clot in our throat, trachea, esophagus, anywhere like that. Monitor for symptoms of hypothyroidism. So once their thyroid is gone, they no longer have that hormone, so you now get to take the levothyroxine, which we'll talk about in just a minute, for life. Because if you had a total thyroidectomy. A subtotal, it just depends on your lab values. Stephanie?
Are these medications going to be on our exam?
They very well could be.
Okay. Can we get them spelled out first so I can look them up?
Is it not in your prep work or need to know before you go?
I'm sorry, I'll look at those.
I'm gonna look, yes. If on your prep work, if you look at pharmacopoeia section on the back side,
Right.
they are all listed.
All right, thank you.
You're welcome. And that propylthiouracil is your PTU.
I got you.
Potassium iodide would be the iodine tincture that we give them. And we'll hit the other drug in just a second. So looking for signs, take all your medicines as directed, because you can actually, if they miss that thyroid medicine, we're going to see in just a second with hypothyroidism, the dangers of that. We're going to check with our healthcare provider before taking something else, because thyroid medicines have a lot of interactions with each other. The other thing that we want to do is, anybody had to give thyroid medicines yet at the hospital? The answer is probably no, and I'm going to tell you why. Most commonly, you give your thyroid medicines early in the morning, about 5:30 in the morning on an empty stomach, because you're trying to simulate your body's natural process. So like in the early morning hours, the same thing that causes dawn phenomenon, right? Those human growth hormones. So in the early morning hours, your body produces all the things it needs for the day in the morning. So one of those is your thyroid hormone, and so we're going to mimic it in the morning. And we would wanna report fever, increased restlessness, palpitation, chest pain, because those things are signs that the hyperthyroidism is getting too dangerous. So fever, we have to worry about febrile seizures once we get super elevated. The restlessness is due to the anxiety. Palpitations and chest pain, though, they can actually kind of have a, for lack of a better word, heart attack. It's not a heart attack, but it's essentially lethal dysrhythmias from the increased metabolism. Worst case scenarios, things that you're gonna monitor for, because remember, the NCLEX wants to know how your patient's gonna, how not to kill your patient or things that would kill your patient. So hemorrhage, that would be from our surgical incision. Our biggest clues, like we talked about, would be that frequent swallowing or your vocal changes, like we hit the larynx. Thyroid storm or crisis. So this often happens when we do subtotal thyroidectomies because a portion of the thyroid's still there, but it also could be for a total, but most often happens with a subtotal. Think about your thyroid is being removed, and so if you rupture the thyroid, all of that T3, T4 can surge out into the bloodstream, and so it's a quick release of that T3, T4, and so it causes a thyroid storm or a thyrotoxicosis. Thyrotoxicosis.
What's the treatment for that? What's the treatment for that?
We are going to give them those methimazole, radioactive, whatever degree, you'll give them an anti-thyroid medicine and then treat their other symptoms. So if it's hyperthermia, what you gonna give for a fever? Yeah, what you gonna give for hypertension? And then think about which class would be beneficial for thyroid because they have tachycardia. Your beta blockers, because the LOLs. Propranolol is your most oftenly given medication for hypertension and tachycardia with hyperthyroid. Propranolol. So Propranolol. Propranolol. Delirium. Not really anything you can give, but you just reorient them and things like that. Vomiting. What can you give them for that? I love it. Which one? Zofran. That's a good one. Abdominal pain. Just more pain meds. Tachydysrhythmias, we go back to that beta blocker. And then chest pain, you will learn about a little bit later, but we would treat it most of the time. What do you know for they go and take by mouth in the little brown jar? So keep it up. Yep, aspirin nitric. There you go. Good job. Bella's in the ER. She's got your chest pain covered. What?
It's the one thing I like chest pain. Sorry, that's wrong. It sounds wrong, but like, when like a heart attack comes in,
it makes your day go.
It's the adrenaline rush, really. So exciting.
It's like
She's so it's sometimes like, it's wrong, but I hope somebody has a stimmy. It's fun.
And they will.
Chest pain, everybody has their thing.
As long as you live in the South, we will have chest pain and diabetes. You will have it. Airway obstruction. So this would happen for your complication from surgery. So notice it says keep a trach tray at the bedside. That is a big hint, highlight, star, underscore. I promise you, if I don't have it as a test question, Hessie loves that. That is a big one. Because where are trach trays kept in the hospital, do you think? In central sterile, no. Our trach tray, well, some floors do have them on, but most of the time they're going to be in central sterile or something like that. And the wrong time to go and acquire one is, oh, you can't breathe? Let me go get a trach tray. Mash the elevator button. Wait on elevator. So have it at the bedside. What's another thing that's not listed there, but would be very helpful to have for airway or airway clearance that should be just set up if it's a trach patient? Suction. You'll be amazed how many rooms you go into. If we're worried about airway suction, they don't have even a canister, a hoop to hold it, whatever. So thyroid patients need that as well. So suction, if you want to add to airway obstruction. High Fowler's position, so greater than 45 degrees. And then medications to reduce swelling. So your favorite NSAID would be an appropriate medicine there. Hypocalcemia. So this comes mainly from the parathyroid. Remember, if the parathyroid gets affected during the thyroidectomy, then it could suddenly release PTH, which is going to give us, it's gonna suck up all of the calcium. And so hypocalcemia from fluid and electrolytes, that's so fun. What is your patient gonna do?
Excitability for their muscles and techniques.
So we're actually gonna, so that EKG monitoring, seizure precautions, and we're gonna give them some IV calcium. All right, and then lastly would be our nerve damage. You're gonna check and make sure they can talk before and after. So we need to know what their tone of the voice is. If they start getting hoarse, raspy, or have trouble forming, then we need to report that so that they do not lose their voice. So, test question. Patient is scheduled to have a thyroidectomy. The nurse prepares what things to set at the bedside? Tray, suction, calcium gluconate. That's your three things for your thyroid right there. So tray, suction, calcium gluconate. Don't wait until your patient has a problem to have them. Go ahead and have those orders on hand where you can snatch it when you're ready. Okay? That's usually why thyroid patients have problems, is we don't prep. We wait until they have a problem. So, obviously your hypothyroidism, we're gonna do exactly the opposite. So if you learn one, you got the other one, just do the opposite, okay? There's all sorts of different types of hypothyroidism. Don't care. I have to just mention it because there's different ones. You may read them. They may be in your book. I'm not going to quiz you on what type of hypothyroidism does your patient have. Personally, it does not matter to me. But just in case you see them, you're aware of those words. So risk factors, surprisingly, it's going to be your females who are going to wind up with this one. And so females, what are other things that happen there at the end of life that causes you to have hormone imbalances? So, y'all were ready, huh? It is. I'm
So we
telling you.
hit menopause and we just
It's
did.
done.
Life over.
Life done. End of life.
I feel sweaty.
Yep. Huh?
I feel sweaty.
Personal summary. So the reason I say it that way though is the end of the range, and women act like it's a big deal. I mean, it's a lot. But you see how this can potentially be mistaken as menopause, but it's really a thyroid issue. So that's a very common clinical thing that happens, is the ladies shrug it off as menopause, I'm just going through the change, when really they have other hormonal issues going on. So that's why I go back to what I was telling you about the thyroid, lump those fertility issues in there with thyroid, because those often get overlooked with hypothyroidism because of what we just talked about in the menopause. So when I start having trouble with my menstruation, they associate that with menopause versus the thyroid. So I always call that out. Use of certain medications, you're going to talk more about those in 114 with your psych and more challenging cardiac things. Lithium is a very common one that loves to knock the thyroid out, and it's used for mental health. And then amiodarone is an antiarrhythmic, and so think about if your patient had hyperthyroidism, and I can get them treated with the methimazole and then amiodarone to control those dysrhythmias for their heart. It also can knock your thyroid out and cause hypothyroidism. So that's why we were talking about in hyperthyroid, watch for signs of hypo. Inadequate intake of iodine yet again. So like we said, iodine helps your thyroid function as it should. So taken for both hypo and hyper. And then we can do radiation therapy to the head or neck. We paralyze, cut, injured, whatever, depending on the type of radiation therapy you get. You injured the thyroid, so now it does not work as it should. So assessment findings, exactly opposite. They're going to be cold intolerant, weight gain, brittle hair falling out in patches, lethargy, tired, no energy. Then they have anorexia, but they'll have weight gain, which is kind of interesting there. And then you see down at the bottom your late signs. Those are the ones that I would most worry about. So they will have hypothermia. They'll actually have a temperature of 95 So that's where our organs will start shutting down and all those sorts of things. So gotta have our thyroid working or we don't have a metabolism. I wish I could blame my weight gain on my thyroid, but I can't. So, but they'll have mental confusion as well. You see slow thought process and speech. So if you have a patient with Hashimoto's, as we'll talk about in a second, we may have to allow for additional response time because it's not that they didn't hear you or not answering, they just have a slower processing speed. And then hoarse, raspy speech, decreased libido, impotence, that side of the coin. So hypo, we said that my brain is pituitary is producing a lot of TSH because I'm, hey thyroid, you're not doing anything. I'm gonna send some more signals, and so TSH is elevated because I have no free T3, T4. And like I said, we can look at those antibodies, but that's a special test, not commonly done, don't really need it, but might be something you're exposed to depending on where you go. Ultrasound again to look at the structure of the thyroid to see if there's something going on that's inhibiting it from working. EKGs, so what would they have in this case? Or severe bradycardia. I'm talking their heart rate's 30, 40. It might be once this week. Severely slow. So that also paints the picture of the brain fog because of perfusion to the brains, in addition to just the hormone itself. And then thyroid scan, we could inject the nuclear radiograph and take a better image of the organ. So cardiovascular changes is going to be from the bradycardia would be our biggest one. Daily weight, so we would worry about their weight gain. Anti-embolism stockings and elevate the extremities, so they will be retaining fluid because of the decreased metabolism, decreased perfusion. So we really have to watch them for DVTs. Respiratory status and ABGs, so what's their respirations going to be? Less than 12, and so we would want to watch for that. Bowel regimen, what they're going to wind up with? Constipation and small bowel obstruction, so we want them going to the bathroom, may have to add on some stool softeners or some good fibrous foods. Love nutrition questions. Yeah. Meticulous skin care, so they're dry skin, so what they're going to need? All the moisturizers, and then extra clothing or blankets. Warm the room within reason, because you also have to work in the room, so don't burn yourself out. But there we go. We're going to do some education because they're going to be so cold. They're going to want electrical blankets, and due to their thickened skin, they're not going to feel the heat as much. They will wind up with thermal burns. Yes, ma'am. So we will, and we actually just electric blankets, as far as the NCLEX is concerned, not a good idea because you can't, control those as much, or people fall asleep with them. We can get electrical burns, all that. Be mindful of their body image. So as this is happening to them, you can imagine, especially because our females or ladies, with hair loss and things like that, that can be very emotional. Then hopefully we can, all of the things that happen to them, you can explain to them that if we can get your thyroid treatment under control, we can actually reverse everything that's happening to you related to thyroid. We would want them to report chest pain because that would be an indicator that their heart is not beating sufficiently to perfuse. And then our medication, notice, try not to change timing, dose, brand, all of that. Because it's hormone based, and you guys probably have the same thing either with birth control or anything that's a hormone medication. We don't want to change because the manufacturing, the way it's compounded, can alter the dosing. And so does anybody know what thyroid medication is dosed as? Micrograms versus milligrams, so very minute type. So that's why that little bitty bit of difference, if you change manufacturers, can. So the best practice when a patient's hospitalized, that they bring their thyroid medicine from home, we get a label and use theirs. Just that way we don't do what we talked about. So what would be some indicators that the thyroid medication was too strong? Hyperthyroidism, so all the anxious tachycardia, about cry, or skin, all those things. And then signs that it's not enough or needs to be readjusted is the increased hypothyroidism. So your one and only medicine for this one, easy peasy. Levothyroxine, or you may hear it called Armour Synthroid, is the brand, good old brand name, Armour Synthroid. But that is your replacement for it, and we do not need to miss that one. Every morning, empty stomach, good stuff. That's about the only teaching there, and then just monitor for signs of hyperthyroidism. Worst case scenario here is the myxedema coma. This is where they have gotten so slow metabolism-wise, their brain just does not function. So it shuts off the executive function ability and can eventually shut off the parasympathetic as well. But they're out of it confused, but it's simply related to the thyroid. If I can get them some thyroid hormone, they should arouse. Just like that, we're done. So you see, that's only a little bit, but we wouldn't have fit that in with diabetes last week. So for time's sake, let me make sure you've got your prep work needs there.
They make it injectable.
Hmm?
They make it injectable.
It's gonna bind up that ammonia and they're gonna poop it out. What are some, I'm worried about my patient with liver failures, clotting times. What would be 2 labs that I could run and check on clot times? Not CBC, PT or, well, PT or the other side. INR. I love INR, it's so much easier than the random number, but that's here or there. That's the big stuff. So what I've got for you, let me stop our recording, is I've got your